Decoding DX is proud to be supported by AMBOSS, a medical education platform with an expansive resource library and USMLE-style question bank. All right, welcome to Decoding DX. We're so excited to have some awesome discussions here today, and I will just go right into it. We've got Dr. Jonathan Chandler, a third-year internal medicine resident. Go ahead and tell us your name. I guess I already said your name, but where you're at in training and something about you that doesn't involve medicine.
Sounds good. So I'm Jonathan Chandler. I'm a third-year internal medicine resident, going to stay on for a chief year next year. Interested in doing a pulmonary and critical care fellowship after that. Something outside of medicine. So I am a huge foodie. Love trying new restaurants, and then I'm a big sports fan. So all about Oklahoma State, where I went to undergrad, and then Chiefs, Royals, Sporting. All the Kansas City sports teams.
Love it. Jack, what about you?
So I'm Jack Nolte. I'm a third year from the Wichita campus, and a non-medical thing about me. I was a cheerleader in undergrad and still like to stay pretty active, so I'm training for a triathlon right now. And I'm planning on pursuing orthopedic surgery next year.
All right, well, we will go ahead and jump on into the case. And John is our awesome scribe tonight, so thank you for being here, John. And we will start out, we're going to get a decent amount of the clinical information in the first aliquot. A lot of this discussion is going to be focused on management type stuff, so it'll be good. So our chief complaint today is a 78-year-old male with a history of COPD who came to the ER with shortness of breath. A brief HPI. He's had about 3 days of this worsening shortness of breath and cough. No fevers, no specific aggravating factors that he can identify. Some mild kind of mid-sternal chest pain that's pretty typical when he has some of these COPD exacerbations. Albuterol hasn't really been helping a whole lot. He's also been feeling quite a bit more fatigued, but that's been ongoing for a few months, past year or so. On initial evaluation in the emergency department, his vital signs were blood pressure of 145/89, a heart rate kind of in the 80s, respiratory rate of 28, and he was satting about 96% on 3 liters of oxygen. On initial exam, he was thin, kind of an older male. He was breathing pretty fast, so tachypnic, but was not using accessory muscles and did have some diminished breath sounds throughout. The rest of the exam was overall unremarkable, didn't really add anything to the clinical picture per se. His initial CBC and electrolytes in the ER were normal, nothing too concerning. His creatinine was at his baseline of about 1. His initial VBG, venous blood gas, was pH of 7.27, CO2 of 99, O2 of 32, and bicarb 34.2. His influenza was negative, and his troponin was negative, and his BNP was less than 15. So Jack, real quick, just starting with you, given kind of this initial clinical presentation, what are the top things going through your mind as far as a differential? What are you thinking for this guy? What do you think would be the next good steps for him?
So it really, to me, sounds like a COPD exacerbation. Common things being common. It does with the lack of fever, or at least lack of frank fever from him being reported, and not having one on his physical exam makes you lean away towards an infectious cause. And then other things that cause shortness of breath like that, heart failure, in his case COPD exacerbation, liver failure, anything that would create an edematous state. But for the most part, common things being common, COPD exacerbation would be my go-to.
That's exactly what we were thinking as well. Jonathan, what are your thoughts? What's going through your mind? And then at kind of the next level, what do you think the disposition would be for this patient? And how would you kind of decide floor versus anything more aggressive?
So great question. So I completely agree with the differential. Jack, I think you did a great job rattling that off. I completely agree. I think COPD exacerbation is very high on my differential, and technically by definition, he meets the definition of a COPD exacerbation. So he's got a history of COPD. He's got an increase in shortness of breath and cough above baseline. So that gives us that diagnosis right there. So we know that that's going on. But then the next thing I always want to think about is what is causing that COPD exacerbation. So there could be something concurrent going on. Could there be an MI? For those that are interested in internal medicine, that is a mix-up question, actually. Someone presents with a COPD exacerbation, the answer is get an EKG to make sure they're not having any sort of concurrent MI. Could they be having any sort of other, could it just be non-compliance, whether that's they're not taking their meds, they're continuing to smoke, are they not on the appropriate therapies, yada, yada, yada. So there's a lot of different things, as to, I want to make sure we're not missing anything else other than just kind of your run-of-the-mill COPD exacerbation. In regards to the dyspho, so I like to think of, if I'm going to send someone to the ICU, what level of ICU care are they going to need? And in this specific individual, it seems like he's got acute hypercapnic and hypoxemic respiratory failure with the fact that he's on 3 liters. I always turn someone's oxygen off when I go into their room in the ED to see what they're actually needing. Inevitably, our awesome ER nurses will turn, and they're great, but they will turn people's oxygen on and they may not need it. But my initial gut, based on this ABG right now, is he's going to need to blow off some CO2. Whether that is with a BiPAP or with a ventilator, we can talk about in a little bit. But that's kind of my initial thoughts right now.
Next up for our patient, he was admitted to the medical ICU or the MICU for the indication that Dr. Chandler mentioned, acute on chronic hypercapnic hypoxemic respiratory failure requiring rescue BiPAP. So he was started on BiPAP with the MICU COPD protocol, which at this institution included a prednisone taper, azithromycin, and what we call duonebs, which is albuterol and ipratropium to help open up those airways as much as possible. There was also just some concern for dysphagia or just not a super safe swallow. So speech language pathology was consulted, and they did recommend a mechanical soft diet with thin liquids. So given that kind of update on the patient's course, Jack, what are your concerns? What do you think is kind of the biggest risk in this patient? What would be the things kind of on your radar just to keep good tabs on if this was your patient, just to monitor his status?
I mean, we want to keep track of that acidosis that we've been talking about, because I know our goal is to blow off the CO2 and to make sure that he continues to oxygenate. So I don't know, a VBG versus an ABG. We had attendings talk about converting those and that efficacy of converting them. I always just answer ABG when necessary because I know how to interpret it. But that would be my biggest concern with him. And then that swallowing, I think, if we thought he's aspirating and that's what's, trigger to this, then I would be concerned with it. If not, a 78-year-old, I could see your average 78-year-old having some trouble swallowing, just something that comes with age and the coordination.
Jonathan, any kind of comments to that?
Yeah, so I'm not sure where we're at in the course. This is day 1 or this is further down the road. Is the swallowing stuff, is that a new or is that more of a chronic issue that just happened to be found?
That was a kind of chronic thing that we noticed when he was admitted. He said he's kind of struggled swallowing for, I don't know, a while now, is kind of how he said it.
Okay. So then this is something that you would want to, this could be a potential just on the surface of this kind of dysphagia, and potentially a silent aspiration could be triggering an inflammatory response. It could be causing potentially a COPD exacerbation. So that's one thought that I had. I think if we're, kind of, as Jack alluded to, you kind of want to serially manage or monitor how their acid base status is doing. But honestly, one of the big things that in these COPD exacerbations, when you have them on the BiPAP, is what do they look like? Do they look improved? Most of the time, they will significantly improve. And when you ask them, they'll say, "Oh my God, I feel so much better." To answer, just kind of give you the little pearl, Jack, on the VBG or ABG. So honestly, it's kind of attending dependent. I have worked with some pulmonary critical care staff. There's a couple of them that say that VBGs really aren't that good, but they definitely can be used if you're wanting to know acid base and hypercapnia, or what the CO2 is. If you are concerned about oxygenation, you should always get an ABG, because the PaO2 on a VBG, as you probably know, is trash, because that's measuring the oxygen, pressure of oxygen in the venous system, which doesn't really tell us much in this standpoint. So anyway, I think hopefully that kind of helped clarifies. I think the ABG is always something, if you're worried about hypoxemia. I prefer, I would love if in the ER loves getting VBGs, but I think when someone comes in with shortness of breath, getting an ABG is great, because it can tell you about their oxygenation and their ventilation.
Another question for you, Jonathan, on the dysphagia. What are some things when you see a patient that would kind of tip your spidey sense to make you concerned that they're not swallowing safely. How do you pick up on that? And then kind of what's your understanding of the differences between like a bedside swallow or actually consulting speech or like a formal swallow study? What do those all kind of entail?
Great question. So for the speech, little clinical clues, and sometimes patients won't know that they have trouble swallowing. So asking things like, "Do you cough after you eat?" Or "Do you have like chest pain, or do you feel like you cough? Like, do you eat late at night, and when you go to bed, do you find yourself coughing when you go to bed?" Little things like that may be telling you that they are aspirating after eating, and they're just not knowing that they're having trouble swallowing. If you ask them, "Are you having trouble swallowing?" they may say no. But having little things like, "Do you cough after you eat? Do you cough after you drink anything?" Stuff like that can kind of clue you in. What I usually do, the nurses on the floor, or especially in the ICU, are really good about being able to kind of pick up on some of these things on like, hey, they're coughing after I'm giving them meds, passing them meds, or they're coughing with this. I have a pretty low threshold to consult speech. My kind of view of everything is that this is a big team, right? So the speech language pathologists, they have gone to school, special training for all of that. So they're going to be able to pick up on things that I won't. That's just their expertise. So I have a pretty low threshold to consult them if there is any question, because it's something easy that they can assess at the bedside. And if they have a concern, that's when they will, if there's some kind of concern and they're not 100% sure, then what they'll do is they'll do the video swallow from there to try and better discern whether or not they are actually having aspiration. Does that help answer that or clarify that?
Yes, that was fantastic. Big plug for interprofessional work there. That was for sure. Our interprofessional peers are awesome. So if let's say this patient initially had come into the ER kind of in the morning and he was admitted up to the MICU kind of midday, you had gotten him settled, gotten initial orders and stuff put in, what would you be kind of emphasizing to the night team as you're handing off?
So if we have them on BiPAP, I would just, one of the things that you may talk about in your subsequent stuff with the respiratory failure with BiPAP, there's some criteria that you need to make sure that people are candidates for BiPAP. So that includes that patients are basically alert enough that they can bring their hand to the mask. The thing that I always do is I have them take their hand and bring it up to the mask, because if they were to vomit, you want them to be able to rip that off. And if they are really nauseous, they may not be a great candidate for BiPAP, because you got to imagine all that pressure. If they throw up, all of it's going to just blow all that stuff back into their lungs. So I would, if there's any question whatsoever about mental status wise, I would always be let the night team know, like, be on high alert. This patient may need to end up getting intubated if their mental status were to decline. So that's one of the big things I think about that makes me a little bit nervous on people with BiPAP. I think, until you can get the speech thing figured out, where they're at from a respiratory standpoint, and typically, especially if there's any concern when someone's on BiPAP, just make them NPO. No one died being NPO for 24 to 48 hours in the hospital, while you're trying to figure things out. So I think having a low threshold to keep people NPO for a short period of time until you can kind of figure that out, you have a lot more risk of someone aspirating on something, especially when they're on BiPAP, than you do on any benefit with them eating and drinking. You can always get that through an IV. Does that help? I think just mental status on someone on BiPAP is kind of the biggest thing, and their respiratory status is probably the biggest thing I would be, wanting the night team to watch out for.
So Jack, real quick, if you're coming in to pre-round on this patient the next morning, what's the first thing you're looking at in the chart? What are kind of the first go-tos for you, just as far as assessing how your patient did overnight?
So for me, I'm going to want to look at, when I'm just doing my pre-charting, specifically if we have any morning labs and what we've ordered. So if we're getting that updated, ABG or VBG, and then I'm going to want to know what the vitals have looked like overnight, and not just what they are this morning, but what the patient's course has been, and if there are any nursing notes or any times they paged to the resident overnight to let them know something, because that'll be important for me to know to present. And then just any updates from consults or imaging or anything like that. That I feel like we overlook that a lot as students because we don't think about that. But that's really key to our presentations. Attendings want to know what the other services said.
And those are great points. And unfortunately, I think it's not terribly uncommon that consult notes don't actually get signed and put in the chart until like 10 p.m. or midnight. So that's a great thing to look for at 6 in the morning. Moving on to the next day, some more info here. On further chart review, you see some notes from his outpatient pulmonologist, and these are his most recent PFTs. So Jonathan, I'm going to super put you on the spot here, but you did confess to wanting to do pulm crit. So can you interpret these at all kind of on the bat, and just kind of what's going through your head? How do you kind of look at results like this to kind of give a quick interpretation of PFTs?
No, great question. So my initial thing, I always go to the FEV1 to FVC ratio, okay? So that looks like it is 75%, which tells me that they're not obstructed, which is kind of interesting to me. Then I typically go, because typically you're looking for an FEV1 to FVC less than 70. There are also some more nuances that I'm not even perfect with, looking at some of the smaller airways and like the FEV1 to FVC or SVC, excuse me, but that's even beyond my knowledge right now. So this, just looking at the FEV1 to FVC, tells me that they're not obstructed. Then their FEV1 is obviously low. If they were obstructed, that would be consistent with like probably, I think it's like severe COPD. So that's kind of what jumps out at me. One of the things that you can tell if someone is restricted is looking at their FVC, and it is low as well. And so it points you that if it is less than 80%, it can point to you that they could have restriction, but you really need full lung volumes in order to assess that. So kind of my interpretation of this would be, it doesn't look like they're obstructed at this point in time, and that there may potentially be some restriction, but would prefer to have full PFTs. And this would have been, I mean, these are old PFTs, is that right?
Yeah, these are from his last outpatient visit.
Okay. One other thing that I just a little plug, if someone were to have asthma, sometimes typically the answer is you never get PFTs inpatient, but sometimes if you have an asthma patient that you've never been able to show that they're obstructed, meaning that FEV1 to FVC ratio is less than 70%, if you've never been able to show that, sometimes once they're clinically stable, kind of on the back end of that hospitalization, there's been a couple times on pulmonary consults that we will get we'll go ahead and get some just spirometry, just like with spirometry is just this. You get these numbers right here, just to kind of better objectify whether or not the severity of their asthma. So just a piece pearl there.
That was super helpful. Jack, any other thoughts on top of that? And does this change your differential at all, seeing these numbers?
In a way, it does. I mean, so our differential was COPD and COPD exacerbation, which is by the name obstructive disorder. And so, like Jonathan was pointing out, like these are restrictive numbers, and it's an old spirometry, so it's not necessarily exactly what he's doing right now. But it makes me think: do we have this diagnosis right? What things about his past history would lead us towards ideas? Did he work in a coal mine? Did he have exposure to birds or farming or all those, joking step one style type things, but actual real life things of, hey, does this person have a reason to be restricted?
I can't remember. I may have missed this. What did his chest X-ray? Presumably, he got a chest X-ray in the ED. I mean, everybody that comes into the ED that's like has a pulse or even not gets a chest X-ray. So, what did that show?
I didn't write it down specifically, but off the top of my head, it wasn't terribly, there weren't, opacities everywhere. There was no clear pneumonia. So it was consistent with a potential COPD exacerbation, which is what clinically we were thinking.
Okay.
Seeing this, there was a note from the outpatient pulmonologist who was concerned that there was a neuromuscular component to this patient's chronic shortness of breath. He had been referred for an outpatient evaluation by neuromuscular, and that appointment was a few weeks in the future, so he hadn't quite gotten to that point yet to be evaluated. So we did go ahead and consult neuromuscular inpatient. There was kind of a discussion about that, which I think was warranted about does this warrant an inpatient neuromuscular consultation? Is he unstable enough for that? Or do we just, get him through this and then let him do his outpatient appointment as scheduled? And I think, honestly, it could have gone either way at that point. We did go ahead and pull the trigger just because we felt like he might have had some difficulty getting to that appointment in the future. We wanted to make sure that he got a good evaluation. So we went ahead and did get that consult. And in their initial evaluation and their history taking, they uncovered that he had been having difficulty swallowing for about the past year, had a little bit of a weak cough, slurred his speech occasionally, and was having a little bit more fatigue, especially in the evenings. That we were finally able to get a hold of his son, and his son said that he had actually lost over 100 pounds in the last year, and he just really wasn't eating. And his son thought that he had lost so much weight just because he wasn't eating. And he was noticeably more tired, going to bed by like 5 p.m. most nights. So given that extra information, Jack, we'll start with you again. Just kind of, again, updates on your thoughts. What's concerning? What does this change about your kind of thought process? And then we'll move on to Jonathan.
So I always actually miss it when I'm taking question sets and they mention a patient having weight loss and associating that with cancer. I'm sometimes not super observant, but I'm glad you pointed that out from the son's history, because hearing a weight loss like that really makes you think, is this, an issue swallowing? He's just not eating and he's losing weight, but losing weight like that without trying, significantly raises your red flags for cancer. And the fatigue towards the end of the day sounds neuromuscular to me, as like the classic description of a neuromuscular issue.
Jonathan, what do you think? And also just kind of your thoughts about how do you approach weight loss in a patient and differentiating between, the different things that worry us.
Yeah, so goodness, weight loss is so non-specific because you can get, COPD patients just can have weight loss because they're working so hard to breathe, they just don't eat and they don't want to expend that energy. So it could be a zillion different things, but certainly with this restrictive pattern potentially on their lung function testing, I think getting some further full PFTs with MIPS and MEPS and all, I throw that out there, which and I'll admit that I just know that that's kind of what you get to work up neuromuscular causes of shortness of breath, and in some institutions it's restricted to pulmonary to even only be able to order those. So for example, the VA, if I had a clinic patient that I wanted to work up for this, I couldn't even do it. I'd have to refer them to pulmonary. So I'm not going to pretend like I'm an expert, but certainly getting that is something that I would be very interested in. But also just getting the total full lung volumes to try and differentiate is what type of, is there restriction, and then what type of restriction? Is this due to more of a neuromuscular chest wall kind of cause, or is it more from like an interstitial lung disease, pneumonitis type picture that can also be associated with a zillion different, like a bunch of different interstitial lung disease processes could also be potentially cause like people to have weight loss and swallowing issues and stuff like that. So like from a rheumatologic causes. So that's kind of where I would be right now. And obviously getting neuromuscular involved is always really helpful.
I think that's a really good point that you brought up, like rheumatologic things. That's definitely not where my mind would go first off the bat, but such a great point. Something affecting the lungs and the esophagus. So a little bit more information. The initial differential from the neuromuscular specialists included a myopathy, inflammatory versus metabolic, a neuromuscular junction disease like myasthenia gravis or Lambert-Eaton myasthenic syndrome, or a brainstem or a spinal lesion. So super broad differential. They recommended a bunch of tests, including a CK and EMG, nerve conduction study, antibody panels, kind of the whole gamut, in addition to an MRI of the brain and C-spine. So given this kind of transition in his hospital course, the team just really kind of agreed that it didn't seem like this fit an acute COPD exacerbation, kind of cut and dry. So we stopped the azithromycin. There was low concern for infection, and actually there was a concern that azithromycin can worsen myasthenia gravis if that ended up being the diagnosis. So since it was not a drug that we were, saw as particularly essential to his treatment, we wanted to get rid of that as soon as possible. That night, so this is the night of hospital day 2 going into 3, he developed progressive lethargy and was determined that he was unsafe for BiPAP. As Jonathan mentioned earlier, there was concern that his mental status, he just wouldn't be able to take that mask off if needed. So he ended up being intubated. And that night he developed delirium and had to be put in restraints so that he wouldn't pull out his endotracheal tube. So Jonathan, going to you, what are kind of, in your experience, the situation and indications for physical restraints? I know that's a really hard decision to make. There's kind of a fine line there. What other measures have you seen be effective to try first, and kind of what are your thresholds for those different situations?
Yeah, so you're absolutely right. It's a really fine line because you don't want to oversedate people because those in the ICU, because those have shown with poor outcomes essentially from oversedation. So you want them sedated just enough when they're intubated that they can, it's like a RAS of negative 2, so they can open their eyes to commands, kind of minimally interact. I kind of think of it as like you are just so tired and like you can't keep your eyes open kind of a thing, is the way I kind of like to think of that. But when someone is pulling at tubes and stuff like that, you really, if you don't want to over sedate them, I kind of have a low threshold, and honestly, we use them so frequently in the ICU of the restraints, soft restraints that just to protect stuff because people get delirious and they don't know what they're doing. We use them so frequently that I kind of don't even think twice about it. And I'll be honest with you, from a practical perspective, usually the nurses just text you and be like, "Hey, we need soft restraints. We need this." Or can I put? They don't even. They were like, "Can we put soft restraints under you?" And especially the nurses here at KU in the ICU, they are so good. If they ask you for something like that, like be friends with your nurses and just do it because they know, and they wouldn't do something. That was completely unnecessary like that if they didn't have to. So I would say to kind of sum it up, I have a low threshold to do it just because, and putting mitts on them without maybe necessarily can sometimes help. That way they can't like physically grasp and, but some people are really good at doing, knocking stuff even with the mitts on. So I feel like that was a long-winded answer.
No, that was great. That's super helpful. That's always, I think, the soft restraints is a topic that I personally struggle with because, just seeing people tied down to the bed just really does it's hard to see, but it's definitely medically necessary. And that was, I think, a big lesson that I learned in 4th year was that sometimes it's it's really necessary. Jack, anything to add to that? Any thoughts about the kind of restraint dilemma?
No, as a med student, ICU, like you said, it's definitely one of the hardest rotations to do, not just from a medicine standpoint, but from getting used to that experience. And
I think that's also really important as a med student to feel, okay with talking to your residents. I know with this patient in particular, I struggled with him having to be in restraints, and I pulled over my senior resident. I was like, do we really need these? I don't think he needs this because he's lucid during the day, but any moment that he would have, delirium by definition is alternating levels of consciousness. They go in and out. So if you were to pull that tube out, he didn't have the strength to be able to breathe for himself. So it would have been very detrimental for him. So even though at sometimes he was, very present mentally, we had to keep those restraints on. And it led to good discussions for me and my resident. So after a few days, the neuromuscular test results did come back as diagnostic consistent with ALS, otherwise known as Lou Gehrig's disease. So that's a hard diagnosis to give. I feel like one of the diagnoses that the general public is fairly aware of, if not what it means medically, at least that it's something that you don't want. So Jonathan, what are kind of the, the way that you approach giving this type of diagnostic information to a patient, to their families? If it's, at an odd time of day, do you typically wait for your attending? Do you do it in the morning? Do you wait until after rounds? Kind of any tips or things from your experiences for these types of conversations?
Yeah, so I think it's totally variable. I think in situations like this, you need to go when you're giving a diagnosis like this or anything that's, kind of terminal and really that's going to alter the course of someone's life. The most important thing is that you need to have time. And if that's in the middle of rounds and you're able to do that with your attending and everything like that, great. If you are, this isn't something that I would, on pre-rounds in the morning in the ICU, I would not bring this up. And you can say things like, we're still waiting for some more test results to come back. We're still we've gotten some of the test results back, but we still want to talk to the neuromuscular colleagues to figure out. I mean, you can find ways to kind of tiptoe around having to give an answer. To be completely honest, because this isn't something that you want to have in like a 2 to 3 minute conversation about, because they're going to have millions of questions and all that stuff, and some of which you may not be able to answer, and that's okay. I think the overarching theme of when the best for this to happen is it's totally variable, but the most important thing is for you to be able to know that you're going to have enough time. This is something that you're like, you hand the team pager off to someone else. You try and stay off your phone as much as you can. I mean, obviously, like nurses are constantly texting you and stuff like that. But yeah, I think just making sure that you have the adequate time, and whenever that is probably the best time to give it.
Jack, have you had any experiences with delivering this type of news to patients?
Yeah, and I will say in Wichita, I've had a lot of experience with this in a language barrier. And seeing that has been really powerful to me. Seeing attendings that actually were trained in, Kenya actually speak in Swahili or their languages they learned in with families directly, or see interpreters being used and seeing the difference in how news is delivered through an interpreter. And that has been really powerful too, seeing how we need to be able to explain that to our patients.
Yeah, that's really powerful. And I think all the more important to emphasize the importance of having an interpreter in person if possible. And if not, then definitely on like a video interpretation service, it makes a big difference. I think oftentimes that kind of gets thrown to the side because we get wrapped up in the efficiency of our workflow in our day, but it makes a huge difference for a patient, whether it's for a big diagnosis or for even just talking about their symptoms, how they're doing that day. It's important to get the right interpretation services for sure. And Jonathan, I really liked how you kind of talked about how, you're not lying to your patient by not giving them the most up-to-date information in the morning, but you're actually, giving them better care by making sure that it's the information is given in the right context and the right time. So I think that's important for students, for residents, for everyone, because I know there's stories out there about students inadvertently given information in the morning that they didn't understand that they shouldn't give at that time. So I think that's important. So thanks for giving that perspective. So to kind of wrap up the case here, there was a really good family meeting with palliative and the ICU team, the neuromuscular team, and family members. This was a good learning point for me. Neuromuscular actually did not recommend a tracheostomy or a PEG tube with this patient. The reason being for that is that they can cause a lot of complications and they don't actually delay any sort of progression. And there's been neuromuscular literature showing that they actually impair the quality of life of those patients in a lot of situations. So in his situation, they did not recommend any sort of interventions like that. The palliative family meeting, everyone did agree to go on with trying a weaning trial, seeing how he would do, but having a do not re-intubate order in place. He unfortunately was not able to tolerate the weaning trials, and the decision was made to go comfort measures only. He was palliatively extubated. He had kind of progressive lethargy and hypercapnia, and he died peacefully later that day. So an unfortunate ending, but a really good learning case for sure, and a patient that will definitely stick in my mind for a long time. So Jack, starting with you, just kind of any takeaways from this kind of case, this discussion, anything that really stuck out to you?
Well, I kind of expected with being a case like this that, common things being common, but this won't be this will be the exception to that. But, really just keeping that broad differential and the ability to change even your entire thought process and path. I mean, midway through rounds, something strikes or a symptom changes, or you get an update from a nurse and something clicks for you that we're not even doing the right thing, I think that really sticks with me that, I mean, you're working out very appropriately for what, presenting like it presented could possibly be. And then it's 180 degrees, not even close.
Jonathan, what about you?
Yeah, I think one of the biggest this kind of case just points to it. The biggest takeaways is always have in the back of your mind, what am I missing? Even if it's the most straightforward COPD case, that you think when you're admitting it, is there anything else I'm missing? And honestly, the person that taught me that was Randy Jensen, who's one of the cardiologists here that started the heart transplant program at Barnes Jewish and has been doing this forever. And the fact that he still, to this day, says, I'm constantly, worrying about what am I missing? What could this be? So I think, always having that in the back of your mind, if you're treating this person as a COPD exacerbation and they're not improving, well, what is going on? And especially getting the PFTs like that. I mean, you got to remember COPD isn't something that happens overnight. I mean, this is like chronic damage to the airway, right? So the fact whenever these PFTs, if they were 6 months ago, it's like, okay, well, seems odd that that they're not obstructed in these PFTs that are relatively recently, and makes you think something else is going on. So I think always just remembering to have a broad differential, and just because you create a differential and narrow that down as you're going throughout the hospitalization, sometimes you have to broaden it back out if things aren't improving or you feel like you're missing something, and don't be afraid to do that. Was this guy a veteran, out of curiosity? Do you know?
I'm trying to rack my brain, and I
It's
want
okay.
to say yes. I wouldn't bet money on that, but I want to say yes.
Well, and I don't know. There's just there's some hypotheses as to ALS is way more common in individuals that are veterans, and there's some hypotheses out there as to why that is. But you'll actually see them at the VA, Kansas City VA, and it's interesting that you bring up about the whole what they said about that trach and pegs does not prolong or prevent the progression, because it obviously doesn't, right? You're just trying to buy them what some would describe as quality of life. But like for example, there's a guy at the Kansas City VA that was in 3 different times over 3 weeks with trach complications and stuff like that. So, I mean, there's just no great way to live. So I think that's interesting that they didn't even offer that.
Yeah, and on that note, mentioning that, I didn't realize that it was more common in veterans, but I do know that the VA will cover, all of their medications if they have ALS. So it's I forget the terminology for it, but it's like 100% service coverage if they have ALS. That's a good point to know. So if your patient is a veteran and they're diagnosed with ALS, see if they can get plugged in with VA care. This was an awesome discussion, guys. Any last minute thoughts or anything that anyone wanted to put out or plug?
I had one question. I was described, but I was just curious about this case. So when they actually made the diagnosis of ALS, this is like a technical side of things. Did they make that based on EMG, or was it imaging, or just looking at him and knowing?
So the clinical picture definitely supported it. I think don't quote me on the official diagnostic criteria, but I know that the EMG was consistent. I don't think imaging had much to do with it. But it was like the EMG, his negative inspiratory force, his full respiratory evaluation, stuff like that, in combination with the clinical picture is how they diagnosed it. All right, guys. Well, thank you so much for being here. This was a fantastic discussion. I really appreciate all your guys' inputs. Anyone who's watching this later on, thank you for joining us. We would love your feedback. Please email us at info@decodingdx.com. Please like and subscribe. It really helps the channel. And join us next time.